Everyone. Sorry, we were just discussing clicker technicalities. Can I try this? Hold on. Is it working? And that concludes my talk today. Okay. Can we go back? Okay, thank you. So good afternoon. I hope everybody's enjoying their lunch and their time so far at the conference. My name is Ellery. I'm a PA. I work with Dr. Nima, Dr. Savajo, Dr. Hannell, and Murley in Endovascular. And I'm very excited to be able to talk to you today about a little what we do, which is thrombectomy. So what great talk doesn't first start with a big statistical slide. So the big takeaway picture for this is that stroke is common. It's one of the leading causes of disability worldwide. And by the end of this talk, 45 people in the US will have had a stroke and 8 people will have died from complications of the stroke. But fortunately, we do have 2 treatments available that significantly decrease disability and mortality. Those are thrombolytics and mechanical thrombectomy. So that's your IV TPA, your T and K. These are, or IV TPA is FDA approved to give within 3 hours of symptom onset. And then mechanical thrombectomy is approved for 24 and above, but it's also tissue based. So we don't use just time to include or exclude someone for a thrombectomy. So what is a stroke? I hope this video works. Oh yeah, it's working. Okay. Simply put, an acute ischemic stroke is when a blood clot travels from the brain or either from the arteries in the neck, and it causes an obstruction in a large cerebral artery. This blockage prevents oxygen from reaching the brain tissue, so it leads to cell death and tissue ischemia. Therefore, when we talk about ischemic stroke, we always say time is tissue. So when we say that, we literally mean time is tissue. That is because for every minute that passes, you are at risk for losing 2 million neurons. And when you lose these neurons, they don't come back. So we think of a core infarct, we think of a penumbra, as shown right here. And the core infarct, when we say that, that means this is the area that's already damaged. So no matter what we do, we cannot get those neurons back. And then the larger area, the penumbra, this is the area that is at risk for damage if no intervention is performed. A very wise mentor once said, you have to think of a stroke as a forest fire. It starts small, it's going to burn a few trees, but over time, it's going to burn the whole forest. Whatever has been damaged, you can't bring back, but the goal here is to put out the fire before the whole forest is burned. Okay, so now we're going to move into a case. So this is a 71-year-old female found down by her husband with lower and upper weakness, facial droop, altered speech. Last known well was 9 a.m. that morning. She has a history of AFib, not on any anticoagulation, heart failure, CVA, GERD. So basically a patient that we see every day. Very typical past medical history. She was flown to Baptist via trauma 1 with the LAMS of 5, which is like a pre-hospital score indicating to us at the hospital that this is very likely an LVO or a large vessel occlusion. So she arrived in the ED at 3 o'clock or 3:02 with a high NIH. A code stroke was immediately called. She was in the scanner 5 minutes later with no acute findings on CT. However, CTA showed a left M1 occlusion. So how are we going to treat this patient? So right now, IV TPA is the gold standard of acute ischemic stroke treatment. However, there are limitations with this. Only 8% of ischemic stroke patients are eligible for IV TPA due to the narrow time window and the risk of hemorrhage. And between the years of 1996 and 2015, which is, if you think about it, 2015 was like 8 years ago. It seems like it was just yesterday, but it was 8 years ago. So between that time frame, the only proven treatment for stroke was TPA. Here's an example of older endovascular trials, such as PROACT 2, which identified patients with an LVO and used intra-arterial thrombolytics to try to dissolve the clot. Also, IMS 123, these are older trials. Although they did show some benefit, thrombectomy never became the standard of care. And then in 2015, these landmark trials, as shown above, proved thrombectomy to be beneficial and superior to medical management, thus making mechanical thrombectomy standard of care, thus allowing Dr. Nema to have a job. So red is the clinical outcome of patients who received thrombectomy, and then gray is the clinical outcome of patients who did not receive mechanical thrombectomy. So you might ask, what specifically between the older trials and the trials in 2015 that helped prove thrombectomy to be beneficial versus the earlier trials? And that is because of the better tools, advances in technology. So we were using stent retrievers to remove clots. We were also using aspiration catheters to remove clots as well, and then better patient selection. So we will continue the case. Just a recap, 71-year-old female found down by husband, left MCA syndrome, so right side of weakness, upper and lower, facial droop, altered speech. Last on well was a 9. History of AFib, heart failure, LAMS of 5. So she's coming in. The hospital staff is prepared to, go all in because this is likely an LVO. Oh, does this have a laser? Oh, really? Oh, okay. That's nice. Nice. Okay, let me get back on track, people. Okay, so in the ED, she arrived at 15:02, high NIH, so 6 hours after symptom onset. Paralyzed on the right side of her body, couldn't speak, couldn't understand. Her CTA showed a left and one occlusion. So she was not a candidate for TPA because she was outside of the time window. So the question is, can we take this patient for thrombectomy? And the answer is yes. It is now the standard of care. It's very effective. So she immediately went to the angio suite at 15:35. So about 32 minutes after arriving to the hospital. This is her CTP. So like we said earlier, the pink area is the area of the brain that's already infarcted. So you can't reverse that. However, the green is the penumbra around the area. So that's the area at risk of irreversible damage if that clot is not removed immediately. So on the left side of the screen, you can see a left and one occlusion. On the right side, you can see that the flow is now restored after mechanical thrombectomy, TICI 3 after one pass. So TICI 3, you might hear like TICI 2A, B, TICI 3. That just means revascularization, like were we able to open the vessel completely back up? Just a fancy way of saying it. This is her post-op MRI. So if she had infarcted the area that's green, the whole left side of her MCA would appear white, as in damage, permanently damaged. She was admitted to neuro ICU post-op. She had AFib, was not on any anticoagulation. She was started on AC. And then you're not out of the woods yet with these stroke patients, like Don was saying earlier, or Wade was saying. These patients still are at risk for UTI. They have to pass swallow eval, and we have great nursing staff. In our ICU we love them because they are the ones that are with our patients all the time. They're looking after them. They're looking at the NIH, like with any fluctuations of exam, they let us know. And I think that's what Don was saying, is how great Baptist is as far as a team-based approach. So, and then this is the patient. So this is an actual patient treated at Baptist, and she was very thankful for everyone, all the care team saving her life. So for future, what does the future hold for thrombectomy? Currently, we are evaluating the benefit of thrombectomy in large bore strokes, distal occlusions, and in patients with a low NIH. So just like how 8 years ago in 2015, this wasn't even a proven treatment, 8 years from now, we can expect more advancements in the field and better care for our stroke patients. Conclusion, time is brain. IV TPA approved for 3 hours or under 3 hours of symptom onset. Mechanical thrombectomy can be used to treat stroke in 24 hours and beyond. And then Baptist is currently offering enrollment in clinical trials. So this helps promote the future of better stroke care for all of our patients. And then this is my favorite stroke quote ever. So I will leave you with this. It is not possible to overemphasize that the care of stroke patients or strokes is not the same as the care of individual stroke patients. The end.